It's a day Teresa and Darren King will never forget. Shortly after moving to their new home in Wapato, near Yakima, their then 6-year-old son Travis wandered away from the house. Teresa described the moment she realized Travis was gone, quote, like her feet were in concrete, end quote. He was eventually found, thankfully unharmed, in an irrigation ditch near their property. Travis King, a 12-year-old boy with autism, and the bill's namesake, joined his family and the bill's sponsor, Representative Gina McCabe, in Olympia for the signing. House Bill 1258, otherwise known as the Travis Alert Act, was originally crafted with Travis and other individuals with autism in mind, until the bill was expanded to address all persons with special needs. Now that the bill has become law, Travis says more lives will be saved.
The bill calls for an assessment of the resources necessary to improve the Enhanced 911 program, so information pertaining to an individual's disability or special need can be available to first responders before they arrive to the scene of an emergency. It would also require the Department of Health, in concert with other agencies, to review existing procedures and create a training program for first responders, providing instruction for how to best respond to emergencies involving individuals with special needs. Teresa King says she can rest easy knowing fire departments and emergency medical service personnel will be provided critical information tailored to an individual's specific disability or need when responding to emergencies. McCabe began work on the bill after the 2015 legislative session when the King family reached out to her with an idea to alert first responders of the presence of an individual with special needs at the scene of an emergency. The Kings had already adopted their own alert system by painting a blue-colored puzzle piece on their mailbox, a symbol often used for autism awareness.
Overall goals of Travis Alert Act are to maximize the safety of persons with disabilities, minimize the likelihood of injury to persons with disabilities, promote the safety of all persons present, provide tools for fire departments and emergency medical services personnel to easily and quickly determine the specific scenario into which they are entering.
Fire departments and emergency medical services agency must ensure their employees are adequately trained and familiarized with techniques, procedures, and protocols for best handling situations in which people with particular disabilities are present at the scene of an emergency.
The training program cognitive goals are to identify ways to maximize the safety on the scene for patients, providers, and the public, to identify ways to minimize the likelihood of injury to a person with disabilities on the scene of an emergency, to identify the following for each main disability topic: definitions, essential tips and etiquette, best practices for communication techniques, best practices for providing assistance and removing barriers, to apply the checklist disabilities, to identify resources for information related to different disabilities. The training program and then cognitive goals are like
The effective goals are to be aware of the importance of understanding and using people first language, to be aware of the effects related to health, safety, and independence, to understand the importance of allowing people to maintain health, safety, and independence, to exemplify a commitment to excellence as an EMS professional in regard to the care of people with disabilities and others with access and functional needs.
Psychomotor goals are: expresses techniques that minimize the likelihood of injury to person with disabilities on the scene of an emergency, express the ability to use the checklist tool, expresses the ability to use de-escalation techniques.
Good morning, Bob.
Morning there, big man. Morning, Alice!
There's no need to be awkward.
Poor Bob. Like so many of us, he just doesn't know how to interact with people with disabilities.
It's pretty easy, really. People with disabilities are people first.
We need the same things that every person needs, like respect.
Good morning, everyone.
Attention!
Okay. Maybe we need to be more specific.
The easiest way to show respect is to focus on the person, not the disability. It's okay. You'll get the hang of it.
One easy way to focus on the person is to watch the person signing and not their interpreter.
Or their companion.
It's really cool that you'd like to help, but do us both a favor and please ask me first. What you think might be helping?
I got you.
Wait, ah! Oh no, might actually not.
If you'd like to offer me help, let me hold on to your elbow. Don't take mine.
Hey, would you like to take my arm?
Sure.
Assistive devices help us to live our lives. They're really important and really personal.
Grabbing them only makes it weird for everyone.
What?
Please only touch our devices and service animals if we've given you permission. And don't take it personally if I ask you not to. Remember that my service animal helps me all the time. Neither of us would like it if we were separated.
Remember, we make our own decisions. We sign documents, vote, volunteer, work, and pay taxes.
We get married.
So don't underestimate me just because I have a great smile.
Just because I'm blind.
May I help you?
Does not mean I'm deaf.
Just because I'm deaf doesn't mean I'm blind.
And just because I use a wheelchair doesn't mean that I can't sweep you off your feet.
So take a deep breath. Relax. We don't bite.
Unless we're really hungry.
Hello there, ladies. How are you?
Hello. And if you're not sure what to do, just ask.
Hi, would you still like to see a menu?
No thanks, but can you please read it to me?
Sure, definitely.
Just treat us the way you would want to be treated, and we'll all be okay.
Good morning.
Good morning.
Morning, Alice.
Morning.
Awkward no more. Nice job, Bob. Go forth and be human.
There's no need to be awkward.
The Americans with Disabilities Act, or ADA, defines a person with a disability as a person who has a physical or mental impairment that substantially limits one or more major life activities. This includes people who have a record of such an impairment, even if they do not currently have a disability. It also includes people who do not have a disability but are regarded as having a disability.
An impairment is any loss or abnormality of psychological, physiological, or anatomical structure or function.
Disability. Any restriction or lack resulting from an impairment of ability to perform a major life activity in the manner or within the range considered normal for a human being. Major life activities include, but are not limited to, caring for oneself, performing manual tasks, seeing, hearing, eating, sleeping, walking, standing, lifting, bending, breathing, learning, reading, concentrating, thinking, communicating, and working. Major life activities also include the operation of major bodily functions, such as the immune system and normal cell growth, which covers people with HIV or cancer.
People with disabilities are people first. People with disabilities are no more easily defined by their disability than they are by their gender, age, race, or national origin. The way we refer to people with disabilities in our communication is important. Lack of awareness about disabilities can lead to unintended stereotypes and discrimination. The way we view and communicate with and about people with disabilities shape our relationships. People's first language puts the emphasis on the person before the disability. Examples given in the table. Refer to a person's disability only if it is relevant. Avoid terms that lead to exclusion. For example, special is associated with separate and segregated plans and services.
Use common sense. Do not separate people from assistive devices or essential equipment if possible. Disabilities are not always apparent. Do not get tunnel vision or classify based on assumptions. Do not assume. Clarify by asking questions. Avoid making assumptions or generalizations about the level of functioning or understanding of a person based on a disability. Do not label people. Many people with disabilities have excellent health. Likewise, use of normal person implies that the person with a disability is abnormal. No one wants to be labeled as abnormal. Always ask if you can offer assistance before you provide assistance. Respect personal space. Be sensitive about physical contact. Always speak directly to the person, not to his or her escort. Be patient and respectful. Apply basic courtesies to all people. Try not to avoid interrupting a person. Do not finish the person's sentence. Do not give multiple commands. Ask or state one thing at a time and allow time for a person to respond.
Communication. The most important tool in communicating with anybody is respect. Treat the other person as you would like to be treated. Identify yourself and others with you when you approach the person. Tell him or her your name and role if it's appropriate. Talk face to face. Maintain eye contact if possible and appropriate. Always speak directly to the person. Unless a communication barrier is obvious, it is best not to assume one exists unless the person, a family member, or other caregiver tells you about the barrier. Even when a communication difficulty exists, the exact barrier and the best way to address it often varies. Communicate clearly and plainly. Avoid jargon. Speak at your regular speed and volume. Do not pretend to understand when you do not. Repeat what you do understand and ask for the part you didn't understand to be repeated. Let people share or indicate how they communicate best.
Community outreach suggestions. Building partnerships with local community resource provides benefits for EMS providers and community members. EMS providers should establish relationships with people within their jurisdiction who have disabilities so that they can better respond to it during emergencies. No one knows the needs or abilities of a person with disabilities more than the person themselves. It is recommended that EMS professionals involve people with disabilities in emergency planning and training. Nothing about us without us is the philosophy that all people have the right to provide input to how they receive care.
Physical disability is defined as a condition that substantially limits one or more basic physical activities in life. Example, walking, climbing stairs, reaching, carrying, or lifting. These limitations hinder the person from performing activities of daily living. Activities of daily living, or ADLs, are the basic tasks of everyday life such as eating, bathing, dressing, toileting, and transferring.
Some mobility impairments are caused by conditions present at birth, while others are the result of an illness or physical injury. Injuries cause different types of mobility impairments depending on what area of the body is affected. People with physical impairments often use mobility aids such as crutches, canes, wheelchairs, and walkers to obtain mobility.
Essential tips and etiquette for people with mobility and physical impairments. Ask how the patient has been transported before. Not all lift, carry, load, and position techniques will be safe. Avoid using the classic fireman's carry. Ask people before moving them from their wheelchair. Do not separate people from their assistive devices. However, most ambulances are not equipped to transport people in wheelchairs.
Find local transportation sources. Example, lift-equipped vans or buses to assist. Learn where special ramps, winch systems, bariatric tarps, and stretchers are available. People with mobility impairments are not deaf, visually impaired, or cognitively impaired. The only accommodation you may need to make are those related to the mobility impairment. People who use a wheelchair, walker, or cane often consider this technology to be an extension of their body. They are part of the person's personal space and should be treated with dignity and respect. Do not lean on assistive devices, push them, or move them without explicit permission. When given permission to push a wheelchair, push slowly at first. Wheelchairs can pick up momentum fast.
Suggested communication techniques. Always ask the person how you can help before beginning any assistance. Even though it may be important to evacuate quickly, respect the person's independence to the extent possible. Do not make assumptions about the person's abilities. Ask people whether they have limitations or problems that may affect their safety. Some people may need assistance getting out of bed or out of a chair, but then can proceed without assistance. Ask. Other questions you may find helpful. Are you able to stand or walk without the help of a mobility device like a cane, walker, or wheelchair? You might have to stand or walk for quite a while on your own. Will this be okay? Please be sure and tell someone if you think you need assistance. Do you have full use of your arms?
When carrying the person, avoid putting pressure on his or her arms, legs, or chest. This may result in spasms, pain, and may even interfere with their ability to breathe. Canes, crutches, or other mobility devices. A person using a mobility device may be able to negotiate stairs independently. One hand is used to grasp the handrail, while the other hand is used for the crutch or cane. Do not interfere with the person's movement unless asked to do so, or the nature of the emergency is such that absolute speed is the primary concern. If this is the case, tell the person what you will need to do and why. Ask if you can help by offering to carry the extra crutch. If the stairs are crowded, act as a buffer and run interference for the person. People using wheelchairs are trained in special techniques to transfer from one chair to the other. Depending on their upper body strength, they may be able to do much of the work themselves.
Carrying techniques for people who use non-motorized wheelchairs. The in-chair carry is the most desirable technique to use if possible. One person assists going down steps or stairs. Grasp the pushing grips if available. Stand one step above and behind the wheelchair. Tilt the wheelchair backward until a balance is achieved. Keep your center of gravity low. Descend frontward. Let the back wheels gradually lower to the next step. Two-person assist. Going downstairs or steps. Position the first rescuer as described in the one-person assist above. Position the second rescuer in front of the wheelchair and face the wheelchair. Stand 1, 2, or 3 steps down. Grasp the frame of the wheelchair. Push into the wheelchair. Descend the stairs backwards.
Motorized wheelchairs. Motorized wheelchairs may weigh more than 100 pounds unoccupied and may be longer than manual chairs. Lifting a motorized wheelchair and user up or down stairs requires 2 to 4 people. People who use motorized wheelchairs probably know their equipment much better than you do. Before lifting, ask about heavy chair parts that can be temporarily detached, how you should position yourselves, where you should grab hold, and what, if any, angle to tip the chair backward. Turn the wheelchair's power off before lifting it. Many people who use motorized wheelchairs have limited arm and hand motion. Ask if they have any special requirements for being transported up or down the stairs.
Deaf, with the uppercase D, is used to describe people who identify as culturally deaf and are actively engaged in the deaf community. Deaf, with a capital D, indicates a cultural identity for people with hearing loss who share a common culture and a shared sign language. People who identify as deaf are often born deaf and sometimes also have other family members who are deaf. However, many people who have hearing parents or were not born deaf but lost their hearing later in life have become part of the deaf community. Deaf people often prefer to use sign language, and it may be their first language. Deaf people have often attended schools and programs for the deaf where they have been able to immerse themselves in deaf culture. People who are deaf take great pride in their deaf identity. Deaf, lowercase d, refers simply to the medical condition of having hearing loss. People who identify as deaf with a lowercase d do not have a strong connection to the deaf community and most likely do not use sign language, preferring to communicate orally. There are a variety of reasons a person identifies as deaf with a lowercase d. For instance, he or she may have been born to hearing parents and grown up in the hearing world with little or no exposure to the deaf community. Deafened or late deafened usually refers to a person who becomes deaf as an adult and, therefore, faces different challenges than those of a person who became deaf at birth as a child.
Hard of hearing. Hard of hearing, or HOH, is a widely accepted term to describe someone with mild to moderate hearing loss. A person who is hard of hearing often does not use sign language as a first or preferred language. This may be due to never having the opportunity to learn sign language or preferring not to. Someone with mild to moderate hearing loss may identify as deaf and be involved in deaf culture and deaf community. Likewise, someone who has a very small amount or no hearing may like to identify as hard of hearing rather than deaf or deaf with a capital D. Ultimately, all people have their own preferred term for how they identify themselves. If you are unsure about how someone identifies himself or herself, just ask. Hearing impaired. Hearing impaired is another commonly used term to describe a person with hearing loss, but many people in the deaf and hard of hearing communities find the term offensive. This is because of the implication it holds of being impaired. However, there are people with hearing loss who are comfortable with this term and self-identity as hearing impaired. However, to be on the safe side, it is best to avoid using this term when referring to someone else. Hearing. Within the deaf culture, the term hearing is used to identify people who are members of the dominant American culture. One might think that ASL sign for hearing is related to the group's ability to hear. Example, pointing when carrying the person, pointing to the ear. However, the sign for hearing is related to the ability to talk. The act of talking is clearly visible to deaf people, whereas listening or hearing is not. From the deaf culture perspective, it is the act of talking that clearly represents the two groups.
Essential tips and etiquette when dealing with the deaf and hard of hearing. In deaf culture, person-first language, such as person who is deaf or person who is hard of hearing, has long been rejected because being culturally deaf is seen as a source of positive identity and pride. Instead, deaf culture uses deaf-first language, deaf person, or hard of hearing person.
A person may present a pre-written note card. He or she may also have some type of recording on device or phone. Be aware of a person reaching for something to present to you. People who have hearing loss may be difficult to identify. Some people who have hearing loss do not accept or identify themselves as deaf or hard of hearing. Hearing aids and/or cochlear implants do not guarantee that the person can hear and understand speech. Some people who are deaf or hard of hearing read lips, while some do not. Lip reading cannot be relied on for communication. Only 30 to 35% of spoken language is visible on the lips. Some people who are deaf or hard of hearing use their voice, and some do not. Deaf does not mean mute. Some who are deaf or hard of hearing may have difficulty with written or spoken English. English may be their second language. Sign language is different from English and might be their first language. Not all people who are deaf or hard of hearing know sign language. There is a wide range of communication preferences and styles among people with hearing loss. Some may use hearing but rely on amplification and/or lip reading. Others may use sign language. Most people who are hard of hearing do not use sign language, while others may speak, gestures, or choose to write.
Suggested communication techniques. Look at the person for whom the interpreter is interpreting. Do not look at the sign language interpreter. Do not exclude a person who is deaf or hard of hearing from a conversation. Take any card or note that is provided to you so that the person knows you have received the message. Then hand it back unless instructed otherwise. A person who is deaf might communicate using written messages or pre-recorded messages. These are used to convey essential information about their activities. Before speaking to a person who is deaf or has a loss of hearing, make sure you get the person's attention. Gently touch the person on the shoulder, extend your arm, or wave your hand. If you are aware that the person is deaf or hard of hearing, flick the lights when entering an area or room to get his or her attention. Follow the person's cues to find out the communication style preference. When in doubt, ask the person the preferred mode. If you have trouble understanding the speech of a person who is deaf or hard of hearing, let the person know. Face the person and offer unobstructive view of mouth. Be aware facial hair on a speaker may affect understanding. Maintain eye contact. Consider using pen and paper. Write slowly and let the person read as you write. Use facial expressions and body language to convey tone. Minimize audible and visual environmental distractions. Do not whisper or yell into their ears. Do not shine flashlight in face or eyes. Use of pen lights for diagnostic information is acceptable.
Consider the use of phone communication applications such as Make It Big, Show Me for Emergencies, Show Me for Emergencies Family Assistance Center, Microsoft Translator, or Translate Me, live translation. If he or she has assistive technology such as phone, hearing aid, listening devices, use those. Also use stock communication tools such as picture communication boards or 100 signs for emergencies.
Blind. A person who is unable to see because of injury, disease, or congenital condition. Blindness. Blindness is defined as the state of being sightless. A blind person is unable to see. In a strict sense of the word, blindness denotes the inability of a person to distinguish darkness from bright light in either eye. The term blind and blindness have been modified in our society to include a wide range of visual impairment. Blindness is frequently used today to describe severe visual decline in one or both eyes, with maintenance of some residual vision. Legal blindness. Legal blindness is not a medical diagnosis. It is a level of vision loss that has been legally defined to determine eligibility for benefits. In the United States, this refers to medically diagnosed central visual acuity of 20/200 or less in the better eye with the best possible correction, and or a visual field of 20 degrees or less. Often, people who are diagnosed with legal blindness still have some usable vision. Low vision. A person with low vision is one who has impairment of visual functioning even after treatment and or standard refractive correction, and has a visual acuity of less than 6/18 to light perception, or a visual field less than 10 degrees from the point of fixation, but who uses, or is potentially able to use, vision, compensatory visual strategies, low vision devices, and environmental modifications for the planning and or execution of a task for which vision is essential.
Visual disorders. Visual disorders are abnormalities in the eye, the optic nerve, the optic tracts, or the brain that may cause a loss of visual acuity or visual fields. A loss of visual acuity limits your ability to distinguish detail, read, or do fine work. A loss of visual fields limits your ability to perceive visual stimuli in the peripheral extent of vision. Visual impairment, often defined as a best corrected visual acuity of worse than either 20/40 or 20/60, a term that encompasses both those who are blind and those with low vision. Additional factors influencing visual impairment might be contrast sensitivity, light sensitivity, glare sensitivity, and light-dark adaptation. Vision loss refers to people who have trouble seeing even when wearing glasses or contact lenses, as well as people who are blind or unable to see at all.
Tips and etiquette for dealing with people with sensory impairments of being blind, low vision, or visual impairment. Always communicate any written information orally. Most people who are blind or have low vision are extremely self-sufficient. Always communicate any changes or dangers in the environment. Service animals should be transported with the person. After having introduced yourself and others initially, re-identify yourself each time you approach a person who is blind or low vision. If providing guiding assistance, allow the person to take you by the arm. If the person has a guide dog, walk on the side opposite the dog. Do not touch the person's cane or guide dog. The dog is working and needs to concentrate. The cane is part of the person's personal space. If the person puts the cane down, do not move it. Let him or her know if it's in the way. When guiding, be descriptive about obstructions. Use directions such as down, right or left. Be sure to mention stairs, doorways, narrow passages, ramps, etc. before you come to them, such as go to your left. There is a curb here, step up. We are going to go down a flight of stairs. We're going to go through a doorway, a narrow passage, or a ramp.
Tell the person if you are stepping away or leaving. If you leave a person you have been guiding who is blind, leave the person by a wall or something other landmark. The center of a room can seem like no man's land. Make the person aware of any change conditions, temporary barriers, remodeling. If you move any furniture to get your ambulance gurney to the patient, make sure you return the furniture to its original location. People who have low vision or blindness often rely on familiarity of their environment to navigate. Any change in the environment may present tripping or fall hazards for them. Always speak directly to the person, not to his or her escort. Do not shout. The person is blind, not deaf. It is okay to use words such as see, look, or blind. It is okay to say see you later or see you tomorrow.
Suggested communication techniques. Take any card or note that is provided to you so that the person knows you have received the message. Then hand it back, unless instructed otherwise. A person who is blind might communicate using written messages or pre-recorded messages. These are used to convey essential information about their activities. Establish eye contact if possible and appropriate. Ask people who are blind or have low vision, "Where do you want me to stand?" Some people may need to bring you into their line of focus. He or she may want to take your hand or shoulder and move you where it's best to see you. Do not move after establishing visual range. Once he or she has you in the field of vision, stay in the same position until you have finished the communication exchange.
Providing assistance in removing barriers. EMS agencies should offer print materials in alternate formats: large print, braille, electronic for screen reader users. In the deaf-blind community, using your fingers to draw an X on the person's back or near his or her shoulder is an indication that there is an emergency and that he or she should trust and follow you. Note, this is used in the culturally deaf-blind community. People who may have vision and hearing loss but are not part of the deaf-blind community will not understand this cue. For the safety of the person, share this information only with the other emergency responders.
Deafblindness is described as unique and isolating sensory disability resulting from a combination of both a hearing and vision loss or impairment that significantly affects communication, socialization, mobility, and daily living. The federal definition of deafblindness means concomitant hearing and visual impairments, the combination of which causes severe communication and other developmental and educational needs. Congenital deafblindness is a term used if a person is born with a sight and hearing impairment, or when the combined hearing and vision impairment occurs before spoken, signed, or other visual forms of language and communication have developed. This may be due to infections during pregnancy, premature birth, birth trauma, and rare genetic conditions. Acquired deafblindness is a term used if a person experiences sight and hearing loss later in life. This can be people who are born deaf or hard of hearing and later experience deteriorating sight. Usher syndrome, for example, causes deafness or hearing impairment at birth and vision impairment later in life. People who are born vision impaired or blind can go on to experience hearing loss at a later stage. Some people with acquired deafblindness are born with vision and hearing that deteriorates later in their life through accident, injury, or disease. For a significant number of people, the aging process is a cause of dual sensory loss or deafblindness. People who are deafblind may not be immediately identifiable due to the etiology, degree, timing of onset, and level of stability of the vision and hearing loss. It is impossible to determine a specific person's visual acuity and/or auditory acuity. He or she may or may not use canes, service animals, hearing aids, and/or a cochlear implant. Deaf-blind does not mean totally deaf and blind. Most people may have some, but very limited or poor vision. Some may be hard of hearing or profoundly deaf. Some deaf people have enough vision to be able to see writing. If someone reaches for your hand, tactile sign, or your face or lips, tactile lip reading, it may be an attempt to communicate. Tactile lip reading is a method of communicating with the blind and deaf whereby their hands are placed on the lips of the speaker. The person with dual sensory loss feels out the shape of the words as you say them. This is similar to lip reading. Not all people who are deaf-blind can use tactile lip reading, and not everyone will be comfortable with another person placing a hand on their mouth.
If a person attempts to lead you to or reaches for something, it may be an attempt to demonstrate an object as a means of communication. Exploring objects should be done in a non-directive way, allowing the person who is deaf-blind to have control. People who are deaf-blind will often need touch in order for them to be sure their partner shares their focus of attention. Look for a communication partner, not the same as an interpreter. In some cases, people with dual sensory loss are accompanied by a partner trained to facilitate communication for the deaf-blind, and they will have developed rapport with each other. A variety of ways exist to speak to a deaf-blind person. The method of choice depends on the level of impairment of each sense. A deaf-blind person may not be profoundly deaf or completely blind. Many deaf-blind people can use sign language if they have some vision. The most common way for a profoundly deaf-blind person to communicate is using tactile sign language or the deaf-blind manual alphabet. Both methods rely on hand contact to communicate. If you are not certain you can be accurate with tactile sign language, do not use this method. Some people know the tactile fingerspelling signs. If you choose to use fingerspelling, place your hand under theirs and form the letters individually in the palm of their hand. The person will likely guide your hand into the correct position. For people who do not know sign language or fingerspelling, it is possible to use the print on palm or POP method by using your index finger to trace the letters on a blind and deaf person's palm. The person may also choose this method to respond to you. Do not use acronyms. Use short phrases or single words.
To get a deaf-blind person's attention, gently touch on their shoulder, arm, or hand. Give the deaf-blind person time to find where you are. Letting the person put their hand on yours may help. Waving hands may not help because he or she may not be able to see you. People may or may not respond to voice depending on the level of hearing loss. Identify yourself every time. A deaf-blind person's vision may be bad enough that he or she can't see who you are easily, nor read your name tag. Their hearing loss may prevent them from recognizing you by voice or spoken name. Print your name and role, for example, Judy, EMT, in thick marker on a card to show him or her. Always directly inform the deaf-blind person of your arrival and leaving. Do not assume that he or she knows you are there or not. If a deaf-blind person has some sight, positioning is key. Do not stand in front of a light source or window, as he or she will not be able to see your face due to backlighting. Position yourself where light falls on you and not in their eyes. Also, if the person is sitting or lying in a bed, sit at the same level so they do not have to look up to see you while they are communicating. Inform the deaf-blind person before you begin to do anything with them or to them. For example, do not move them or grab their arm without first explaining what you're about to do and why.
Check frequently for understanding. If an emergency happens and you must exit with the deaf-blind person quickly, draw an X on the deaf-blind person's back with your finger and lead him or her out by the arm. X on the back is a universal deaf-blind sign for emergency. If back is not available, draw an X in their palm. Note, this is used in the culturally deaf-blind community. People who may have vision and hearing loss but are not a part of the deaf-blind community will not understand this cue.
This is the end of Part 1. Please proceed to Part 2.